Hey everybody, welcome back to the Monday Afternoon Journal Club, the first installment of 2025, and we tend to be jumping on just as the world is catching on fire. So welcome to 2025, Danny. How you doing?
Oh, we're doing great. We're doing great. Can't say anything more that hasn't already been said. Go Birds.
It's so go Birds indeed. Look at that Eagles lid coming fresh off the divisional victory. We're a week away from the Eagles going to the NFC Championship game, so I'm psyched. But first, before we get into too much sports enthusiasm, because I do think the Eagles are going to do fairly well this year, let's go ahead and talk a little bit more about ketamine, because, Danny, we found another study that shows that we really don't know what we're doing with any. So this data set.
I have feelings about this. I'll get into it.
We're doing the thing. We got big thoughts. So this paper is coming from Greer et al. This is out of Hamilton, Ontario. And this was a very, very specific study, which if you've watched the Journal Club before, you know is kind of our bag. So what happened in this study, this is a meta-analysis. They went over 7 randomized control trials for a total of 2,384 patients. And what they looked at was essentially how Etomidate versus ketamine worked in rapid sequence induction for intubation. So this is kind of our wheelhouse, right? This is what we do. Whether or not we use ketamine or Etomidate or rock or sucks is kind of this ongoing debate in EMS. What's fun about this study in these conclusions is, and here we have the conclusions down at the bottom, we're going to go over into the text of the data in a minute. Compared with Etomidate, ketamine probably results in more hemodynamic instability during the peri-intubation period and appears to have no effect on successful intubation on the first attempt or mortality. However, ketamine results in decreased need for the initiation of vasopressor use and decreases adrenal suppression compared with Etomidate. So what this paper is essentially saying is that ketamine may be a better induction agent, but for a very brief period during that induction, the patient might need hemodynamic stability, whether it's giving, temporizing your blood pressure with saline or whatever. But you also didn't need to use vasopressors, so something, like an alpha drug or anything like that to increase their blood pressure. And then we talked about it decreases adrenal suppression compared with Etomidate. We know Etomidate can cause adrenal suppression, which is all kind of stuff that really, that feels like ICU stuff, right? That feels like ER stuff. That doesn't really feel like pre-hospital stuff. But the grand 10,000 foot view here is that you can use ketamine or Etomidate. They'll facilitate your RSI. And again, people that have been following the show know that we tend to prefer ketamine. But Danny, I know you got a lot of feelings about this paper, so let's hear what your thoughts are.
All right. I'll just.
All right. Everybody strap in for a second.
Strap in, because this is going to get salty. Listen, I love academia. I love reading these papers. I love doing journal clubs and sharing with everybody what we do. This ketamine versus Etomidate has been like a 20-year, East Coast, West Coast rap war. And we still, everything comes out.
We got one crew doing the Etomidate walk, another crew doing the ketamine walk on the side.
It's just,
step this way.
We do this over and over and over again, right? And the definition of insanity is doing things over and over again and expecting the same results. And we're getting the same results, and we just keep doing these papers. Here's the thing. Either agent works. Yes, if you push ketamine rapidly, I bet you do get a little blood pressure instability. You get some issues. There are places that are already starting prophylactically a little bit of push dose epinephrine or even an epi drip while you're starting your RSI process. And I think I'd like to see studies on that to see if that works. I think the big thing here is we're looking for a magic bullet, right? We're trying to make sure that one agent, it's like the one ring to rule them all. And it's not true. It's just bullshit. Here's the thing. Use whatever agent you want. Use ketamine, use Etomidate, use propofol. I wouldn't, but fine. Do your thing. How about we just keep these patients from not getting hypotensive and not getting hypoxic during the intubation process, and we work on getting a good, smooth intubation on the first pass. Dash 1A standards, which gets pushed around and people like to talk about it, but nobody actually reinforces these ideas. And this is the big problem with this stuff. It's all academic, and we're still battling this ketamine Etomidate out, and the evidence clearly is showing, look, either one of them do just fine. The big things for your patient are hypoxia and hypotension We know how to counter those. We know how to protect our patients better. Stop the insanity. Let's just stop doing these. Let's go look at other things in airway management that we really need to see about.
No, I think that's right. And yet again, we've been talking about this for years, right? Everyone that listens knows that we're more pro ketamine than pro Etomidate. But we also, I think, have conversations, and this is one of those conversations you have on the truck, right? Does it really matter, right? If what we're trying to do in the pre-hospital arena is to establish an airway and make sure the patient lives to the hospital. Now, there's plenty of conversation that we can have about how pre-hospital medicine affects in-hospital medicine and downstream. And I'm completely on board with that. But I think at certain times, we have to start looking at what the patient's acuity actually is, right? And you and I can have academic conversations and debates all the time. It's one of my favorite things to do. But at the bedside, that's not the time to have the academic discussion, right? So if you're and again, you have to consider the intangibles that we see in the field, right? You go out into the field and I have to RSI someone in their bathroom and I have to hang upside down to do it, right? In that context, what is going to facilitate the intubation is the right answer, right? If you're intubating someone in a hospital, and Danny, you and I have done this in hospital settings as well, there's a lot of more control. There's a lot more people you have. You can take the time to have that academic conversation of, well, maybe this is someone who's a little bit hypertensive, so it might be an adrenal crisis. They might, there might be some problems there. All right, you know what? Let's go for Etomidate over ketamine. You can have that conversation. What tends to happen pre-hospital is we tend to get patients who are either moribund or who are peri-intubation in the beginning, right? So we're already behind the 8 ball when we're actually trying to start this process. So what is going to get the tube into the patient's trachea in the fastest, most efficacious way? That, I think, is really what needs to be the conversation. And whether that's what total cocktail is going to improve your first pass success rates, whether it's Etomidate, Sux, and morphine, if we want to go 20 years back, or if you want to use ketamine and rock and fentanyl, whatever is going to maintain and establish that airway is what you actually want to get. Now, if you're a clinician who is like, my practice is I use A, B, C, D, great. Keep doing that. This is not something that necessarily changes practice. This is just something to kind of have more of a heads up of, if you have a patient who's a dialysis patient, right? They're in a situation where they need an airway. Maybe you want to consider using ketamine over Etomidate because of that, the adrenal surge or whatever. Those are the kind of variables that you want to look for. But this doesn't necessarily talk about every patient that we see in the RSI setting.
No, it doesn't. And like you said, not, everything it looks like a nail, when all you have is a hammer, everything looks like a nail.
Looks like a nail.
And that's fine. And I don't mind Etomidate. I will use Etomidate. If I have a brain bleed with somebody who's got a systolic BP of 220 or 230, I might go with Etomidate over ketamine. That being said, the big thing, the agent doesn't matter. Okay, we're in the weeds with this stuff. This is high level academic stuff. The fact is for us in the field, the things that matter are hypoxia, hypotension, and first pass success. And those are the things that are going to save our patients. It doesn't do us any good to be able to have a cogent argument about what agent to use if you're not doing that on a regular basis. Your patient's still going to die in the ICU. If you don't want them to die in the ICU, you're going to take the steps to temporize that and to stop that from happening. And then I think whatever agent you decide to inject in ain't going to make a difference.
And I think that's right. And again, it's more the conversation of what's going to get that tube passed, right? What I think is great about academia, and actually one of the things I like about this paper, is that it's looking at nuance, right? I back to your point from earlier, is people want to have this magic bullet, right? All right, this drug is what's used for this. And it's one of the reasons that we protocolize so many things, right? Where it removes that cognitive offloading or the cognitive offload of actually having to think about what to give and when to give it. And the reality exists that our patients are different and dynamic. So you're going to have different presentations, you're going to have different medicines that will work better for different patients. Data tends to look at the bigger picture, right? All right, if in a year you perform 100 RSIs, 80 of them probably should be done with ketamine because that's typically what the patients need. But you might have 20% that need Etomidate, right? It's using the proper tool in the proper setting. While I do like that this kind of goes into minutia over in the actual specifically, the peri-intubation period, it might be better to use etomidate over ketamine because you want to temporize their blood pressure. I think the counter argument to that is, well, if you have fluid running to keep their preload at a certain level, then you don't really have to worry about that moment of hypotension if you're giving ketamine, right?
But but we don't have anything to hang our hat on because we don't study that.
Right.
It's much easier to do another ketamine etomidate study than it is to actually look at a systematic, how do we temporize blood pressure during the peri-intubation phase? That's a little harder. I don't want to do that work. Let's do a ketamine etomidate study.
Right. And that's the rub, is that doing that study would actually be very labor intensive. It would cost a lot of money. You'd have to go through an IRB. It would cost time, which is why there were rat studies done on etomidate a decade or more than that, 2015, that showed that it might cause adrenal insufficiency. So, we've gone in a decade, we've gone from it probably causes these problems in rats to it probably causes this problem in humans. And that's not to disparage or take away from the work that these researchers have done. It's incredible work. What we know now is logarithmically more than what we knew 10 years ago. But we're still in a position where it's like, okay, we have all this data, and it turns out that what works, right? You've got to establish an airway. We can have the academic debate a little bit later of, okay, well, you know what? You gave this patient ketamine, their blood pressure dropped. Maybe next time give it time. You can have that conversation, but that's where it gets down to almost like a single type of QA sort of issue, which again, I think is very difficult for organizations to perform. So we want to know what you guys think. Again, our practice is typically to use ketamine. Etomidate seems to kind of be falling out of favor and has been for a while. But we want to know what your shops do. Do you guys use etomidate to try and avoid that hypotensive risk? What are you guys using? Check out all of our work on Spotify, on YouTube. We're still on TikTok because now it's back. Wherever else, check out our news stories on EMS1 as well. For the Overrun, for Journal Club, Ed Bowder, Dan Schwester, we'll talk to you all next week.
Go Birds.
Go Birds.